Good morning. I just popped in to say that we'll actually start at 9:05. So if you need a chance for a wee or a coffee or any of those things, then take the opportunity. And I'll see you in a minute. Hello, morning. Right, I think I've got everyone that we're expecting. So if you're happy, we'll start, if that's okay. If I could just ask, I'm quite happy for cameras to stay on for the rest of the session, but if we could just turn it on at the beginning, please, just so that I'm not talking to a blank space. And then when we're done, like I said, I'm happy for the rest of the day for you to leave them turned off if you need to. Good morning, faces. Hello.
Morning. Morning.
Good morning.
Hey, Brie.
Fran, my
Yeah.
camera for some reason will not turn on. I don't know why. It says
Alright,
it's not available.
Fine. Like I said, we can do without it. I've got someone to look at, so I'm feeling all right. Good morning. Welcome to KT Bookings Training. Welcome to the brave new digital world. How exciting. So I'll tell you a little bit about the overview. You can't hear me, Amy. Oh no. Have you got your sound settings on your laptop, right? So if you went to in the bottom box, let's share my screen a second. See if I can find the right place. If you go in here and you go to control panel, and then you go to sound, and you go in here, just make sure that you've got the right thing selected. So you need to have audio driver for display audio. This one at the top, yours should look something like that. And that should be the one that you're using. If that doesn't work, you could try using speakers instead. See if that works for you. Or, really simple thing, have you got your volume turned up on down here on the right hand side? But I realise you can't hear me.
I'm good. It was the speaker. I don't know, the volume's, it's fine now.
All right, cool. All right, good morning. I'll do that bit again. Hello, welcome to KT Bookings Training. Let's talk to you a little bit through the process we're going to go through today. So we're going to have a little conversation at the beginning about what the system is, what the system does, why we're going to use it. I'm going to show you a video that's an overview of the part of the system that we're going to be training on today. We're going to run through a booking. We're going to run through also how you do postnatal triage. And then this afternoon, we're going to do routine antenatal. And then I'm going to get you all set up on the test system so that you can go in and play with the system yourself. So the run through usually finishes by about 2 o'clock. So those couple of hours in the afternoon, I'm going to ask you to then go into the system and play yourself, because I can show you as many screens in the world as I can. But where you're actually going to learn is by going in and playing with the system yourself. If that works for everybody, if everybody's happy. Cool. All right, so I'll start with the question. What is K2? Just from you guys' perspective, what you know about it, what's it going to do, why are we using it, what's it all about? Feet on a cliff, you should have an answer for this at least. Go on, what is K2 and what's it going to do?
It's going to get all of our bookings and all of our notes online.
Yeah, perfect. So K2 is what we call an end-to-end maternity information system. So it covers every element of the maternity journey. So the system actually lives in 3 parts. So you've got My Pregnancy Notes, which is the woman's online portal. You have Athena, which does antenatal, postnatal care. So that's inpatient and outpatient. And then you have Guardian, which does intrapartum. So today we're going to be training on Athena. In terms of the process for the future, what it looks like. So at the moment, currently, when women identify themselves as pregnant, they go to the website, they fill in a form that goes to a bookings inbox that Helen and Emma then go pick up. They organise the booking, you get the appointment schedule, and then they're booked into midwifery care. So what's going to happen in the future is they're still going to go to the website, but when they go there, they're going to click through to a K2 account registration. They're going to provide some initial information about their social history, obstetric history, medical history, and they're going to create a referral into the system, which Helen and Emma are then going to pick up and book them an appointment. It goes right the way through. Every element of the antenatal pathway that we document as we go then becomes visible in intrapartum, because Athena and Guardian are linked. And then the information from Guardian feeds back into postnatal, and we cover that entire journey. So I'm going to give you 3 reasons about why we need to use the system. So one of them is about CQC feedback. So one of the key recommendations, one of the key priority areas coming out of the feedback we had from CQC is about introducing the IT system as soon as we can. And I think as we go through, you'll see actually why that is such a priority. You realise what an information light environment we work in at present, and how using the system will give you incredible visibility on the risks associated with that pregnancy. The other reason, I'm actually going to give you 4 reasons, sorry. The other reason is about maternity transformation programme. So the government says that women have to have access to their own online notes by 2024. And that's about generating autonomy and personalised care for women. One of the other reasons is about finances, essentially. So data that we currently collect, that we have to collect, so it's mandatory national reporting, we collect using something called the Maternity Services Data Set, which is a set of information about the care that we provide. And also that's linked to something called payment by results. So back in the day, we used to get a certain amount of money from central government for the delivery of services, and we chose how we spend it. Nowadays, we deliver care to guideline and then we get that money back. So as it stands at the moment, our data records are patchy. So I cannot absolutely put a figure on how proper data reporting is going to increase money into the system, but I have no doubt that it is going to improve our ability to return that funding, because we're going to get really good sight actually on what we're doing and when we're doing it. The other one is about the clinical negligence scheme for trusts. So because Protos, which is what we're using at the moment to generate MSDS, because it's really old, I've not been able to update those data sets, which means that we cannot complete Safety Action 2 of CNST. So that means that we're automatically eligible for a £400,000 a year rebate back into service funding, because we can't return that data. So PBR, I think, is going to see increased money into the service, but definitely CNST compliance is going to bring that up to £500,000 a year back into the service. Fee, I see your hand.
Yeah, Fran, you're probably anticipating anyway. If all of our data is recorded on K2, does that mean that we can not record on IPM? Have we gone back? Have we sort of got to the bottom of that?
Well, so the thing about IPM is that IPM facilitates K2. So IPM and K2 are linked. So it means that when we put appointments into IPM, that is the trigger to pull them through to the online portal. So we do still need to use IPM, but it's to bring the information into K2.
I mean, I think I was talking about for payment. So obviously we've got to outcome, arrive, outcome, and but we've had that conversation, haven't we, about do we need to do that because we're already getting paid for it anyway?
I'm in that conversation. I need to make the administration understand about the intricacies of maternity funding, because we're not funded like anyone else. I spent half my life going, it doesn't quite work like that in maternity. But yes, I'm in that conversation. I believe that will be the outcome, but I'm not quite there yet.
That would be good.
Yes,
that would be good.
Yes, it would. Yeah. And then the other reason about why K2 is important, so this one's a bit of a personal one, and I shared it a bit off the cuff in one of the first training sessions, and the group there were like, you have to go and tell everybody this story. So I'm gonna just go tell the story, and some of you already know the story, about the reason why I'm the digital midwife. And I'm the digital midwife because I was involved in a delivery 2 years ago that had the outcome that nobody ever wants to come from a delivery. And in the wash up about why that happened, the risk in that pregnancy wasn't as visible as it could be. It was lost in a sea of paper. The communication wasn't what it could be because it was lost in a sea of paper. And in the sort of wash up that you do in your own head about what happened and why it happened, I had a conversation with Kerry Staples, and she casually said to me, yeah, well, K2 is going to make that better. And I was like, what is this K2 thing? What is it and what does it do? And essentially, I then started turning up to the meetings because I thought it was interesting, and quickly realised that this is the greatest thing that we can do in one single action for safety and quality across the service. And a couple of things that just sort of bring it home for me. So one of those is about risk assessment. Throughout these training sessions, after booking, the training's being taken over by the digital transformation team. So you'll see those folks for the rest of the schedule. They will hammer it into your brains. I will hammer it into your brain to press the risk assessment button. And that means when you hit that intrapartum setting, any risk associated with that pregnancy will be visible, so that the midwife walking into that room for delivery knows exactly what they're dealing with. And also some stuff that I've been doing last week now around intrapartum risk assessment. There's this one little bit of functionality that was, for me, the key thing that I had to deliver. And they demoed me it last week, and then I cried for 15 minutes, as you do, because it's a really simple bit of logic, but it is when you are doing your initial assessment for fetal monitoring, at the first screen, it says antenatal risk present, yes, no. Evolving intrapartum risk present, yes, no. If you go to the next screen and you have indicated yes for either of those, and then you select intermittent auscultation, it has logic built where it says, are you sure? It goes, there is a risk that you have identified. Are you sure you've selected the correct method of monitoring? So it's little things that will just make big changes, because, you know, those families that we look after deserve the very best care, but you guys deserve the very best information to go in and do your job in a really, you know, effective, compassionate, you know, concise fashion. So yeah, I'll stop talking about that, but I was told to tell you all because apparently it makes it real. So there you go. Okay, so the first thing that we're going to do, if that's all right, I'm going to show you a video which does the overview of the Athena system. Now, I'm hoping that it will let me play. So if I stop sharing that, start sharing that. Screen. Now, it may not play the audio initially because I'm never sure which setting it's supposed to be. So it should have audio. If you can't hear it, please can you shout, and then I'll start it again. Okay. Should be that one. Can you see the screen with the video on it now? If you just nod for me. Okay, and I'm going to press play, and as I said, tell me if you can hear it.
I can't hear anything, Fran.
In this video, we will be outlining the functional navigation of the K2 Athena system. Please ensure that your username and password have both been set up prior to accessing Athena. Upon logging into the system, the first page you will see is the home screen. For ease of navigation, this has been divided into 5 separate tiles. On the home screen, you will also be able to adjust your settings via the Tools wizard. Here, you can view software information, adjust the font to your preferred size, see any updates, view the log file, change your password, check your network connectivity, and view regulatory information. It is important to note, once you are finished using Athena or are away from your device, you will need to either log out, exit, or lock the system. This is in order to comply with information governance and data protection laws. There are various ways that you can find women that have been admitted onto the system. The first being via the Locations tile. Here you can find clinics as well as inpatient wards. In this example, we will look at an inpatient stay and show you how to admit a woman to Argyll. At the top of the screen, you will see the Admit Woman button. Clicking this will take you to the search bar where you can find the woman you'd like to admit, either by inputting their hospital patient ID, NHS number, name, or date of birth. Each woman admitted will have a 3-dot menu where you can select some quick actions that need to be undertaken. Or you can go into the View Full Inpatient Notes, and this will include everything that can be entered throughout the inpatient stay, in managed tabs for ease of access. These tabs include admissions, management, risk assessments, clinical assessments, observations, specialisms, investigations, fetal assessments, procedures, labor, and outcome. Going back to the home page, we will now look at the Teams tile. The teams are separated into different staff groups for ease of access. The first one we will look at is Specialist Referrals. Behind this screen you will see Pending Referrals, which the team can either accept or reject. We also have our Consultant teams. Here you will see all women assigned to a consultant. Next is the Midwifery team. Here you will see all women assigned to a midwifery team. You can also filter the search so that you can see women assigned to an individual midwife. In the Management of Women team, you will see a list of all women. You can filter by teams, assigned midwife, and assigned consultant. There is also a safeguarding team that women can be referred to. The third tile is My Desk. Next to My Desk is the Quick Tasks tile, which can be used for a new booking or to enter delivery information. For a new booking, once you click the button, you will have the option to search for the woman you would like to book. You can do this by inputting her hospital patient ID, NHS number, first name, surname, or date of birth. The final tab on the home screen will be mainly used by admin staff and team leaders. Here they can create custom reports from data that has been entered into the system. Here you can see the search button. We will now use this to search for an example woman. Please note these are test patients and we will not be using real patient data. Once you have searched for your patient, the system will ask you to confirm that you have selected the correct person. You will need to check and select yes or no. This will take us into their main notes. The main notes are divided into sections at the top, and when you hover over them, more selections will appear. The tabs are divided into the woman's profile, obstetric profile, medical profile, social profile, screening profile, plan of care, communications, pregnancy outcome, and audit. The next tab is the Consultations and Admissions, where you can view any helpline contacts. You can view the booking to-do list and all information entered. You can view antenatal consultations, see hospital stays and visits, and lastly view postnatal consultations. The Antenatal tab includes plan of care, observations, specialisms, procedures, investigations, fetal assessments, and pregnancy outcomes. This is designed so that anything entered during an inpatient stay or consultation will all appear here in one easy-to-view place. This is the same for the specialisms, where anything entered will pull through. In investigations, you can view investigation history and make more offers if required. Next is the intrapartum section. This is mainly covered by the Guardian system, but here you can see anything intrapartum that has been added against the woman, view baby information, and view reports. Then you can view the postnatal section, with the postnatal summary, observations, investigations, baby checks, plan of care, checklists, and discharge from care to health visitor. The final tab across the top is the green baby button, where you can view previously entered information, as well as record new information regarding the baby post-birth. On the main notes screen, you can also see several icons on the left-hand side. The risk flower in this instance is pink as the pregnancy is high risk. If the pregnancy is low risk, the flower will be green, and if data is yet to be entered it will be grey. You can select the flower to perform a risk assessment and view active risks. Next is the meds icon, which should be used to enter any patient medications. The final icon can be used to add a new referral by selecting a referral reason and destination. There is also an Actions tab where you can view active actions, add new ones, and view completed ones. The 3 icons here are indicative of domestic abuse, social services involvement, and safeguarding. These icons will change, depending on what is added in confidential mode. Confidential mode can be accessed by clicking the C in the top left-hand corner and authenticating. Once you go into confidential mode, look at the social profile where there are more tabs available to enter. These are highlighted with the flashing C to indicate that they can only be viewed in confidential mode. If you leave confidential mode, the C icon acts as a prompt to let you know that there are more hidden tabs. This brings us to the end of the functional navigation of K2 Athena. Thank you for watching.
You're on mute, Fran.
Any initial thoughts looking at that? How does it make you feel? What's your first impression?
I'm excited. It looks really good.
Good. That's the
There's
upside.
there's quite a lot. Like at the
Mhm.
minute, I think there's quite a lot of tabs, and I think I'm quite sure that it's very easy to access. But is it going to be a, you know, if you're looking for risks in a set of notes,
Mhm.
are you going to have to remember to look for loads of different places to find what you need
So,
to in K2? Or although you said, didn't there, there's a risk
yeah.
button.
So let me just show you some stuff to answer those questions. Let's click over here. Oh, it's because I've got this open. Bear with me. Okay, so I'm just going to log in and then I'll share my screen again. 1 second. Okay, so if I share this one, I can answer both of those questions for you. So first question was about, is it going to be difficult to share all the information? Do you know what? I'm just going to share on the other screen so I can just see faces. So bear with me. I'll move over here. Let's use that one. Okay, so one of the things that you might hear me talk about today is structured data. What does structured data mean? So structured data is information that you enter in one part of the system that the system knows needs to appear somewhere else. So if, for example, we're going in and we're looking at a patient, let's look at poor Alison Abel. She gets all sorts of investigations and stuff happen to her. So if, for example, you go into her booking overview, so in her, where's she got information? Observations, where's a good example? So what I mean by structured data is in her pregnancy profile, she had been given, what's because she's not really got enough. Hang on, let me find one that's better. Let's use Susie Cole because she's been fully booked. So if you go again into Susie's booking overview, so her booking's been fully completed, and you can tell because down this side she's got full circles against the information. So if you go in her medical profile, for example, it has been indicated at booking in one of the booking wizards that she's diabetic. So that means that when you go over here and you go to her medical profile, oh no, it's in here. her medical profile, the information about the diabetes is already been pulled over. So there are lots and lots of tabs and screens, but that data is continually moving and flowing from one place to another. So those tabs are not like you need to enter information on every single point. It just means that you've got individual specialized places where you can go look at it if you want to. And the other point about visibility of risk. So this button up here that I lovingly call the Ockenden button, I am going to just, as I said, push really hard, and in all the training sessions you'll get pushed really hard about this, about pressing this button. So you press this and it tells you that she last had a risk assessment on the 11th of October. You can assess her again now, but based on her last risk assessment and also information that's been entered on the system. So some of it is risk that you've identified. Other places are where the system goes, okay, she's been entered with a high BMI, she's been entered as having diabetes. Those risks automatically come over. And you can go in here and you can also add new risk if there's something that you believe should be there that is not. And we will go through the risk assessment as part of the booking, so I won't do it now, but just to highlight to you that button, that's what that button does. And so let's go and do just a little bit of navigation around the screens that you saw in the video. So remember, we're in the test system, so not all of it's going to look perfect. It's not going to entirely look like live. It's still a work in progress. If you go into your locations, you can see all of the different wards. So if you want to click onto Argyll, those are our patients that are currently sitting on Argyll. And you can click in there and you can look at their notes, you can move their wards, you can discharge them. I'll make a note here for you about discharge removed from ward. So you're going to get this again in the inpatient and postnatal inpatient training. In order for a woman to appear in the community space for triage, she has to be discharged from the ward. So if she's discharged, she'll disappear from the board. So if you're working in the inpatient setting and you're sending them home, please make sure that you complete this action so that she ends up in the right place, please. You can also, triage will run from here, for example. You can see women that are currently receiving care for home birth. You'll also be able to click here. This will have all of the IPM clinics. So you can look at women that are coming up in your clinic for the day, but you've got other ways that you can pull that information as well. So I'll show that on a different screen. So if you go into Teams, so these are what we call the doors. So what we're going to talk about today is putting women behind doors and putting women in briefcases. It will become like standard vocabulary for you. These are your specialist referrals. So women can live behind multiple doors. So Susie Cole, that I was just looking at, she's diabetic, so she can sit behind the diabetes door. Pending referrals. See, there she is. So she's had a diabetes referral that's not yet been processed, but she's behind that door. Say as a result of that, she has been allocated to IMO, so she'll sit behind IMO's door. However, for her care, potentially she's being looked after by Green Arc team, so she'll be behind that door as well. So there's all these different ways that you can get to women's records. One of the really key areas for you in community midwifery is going to be My Desk. And here essentially is your caseload management. So my assigned women, so these are all women that have me nominated as their midwife. But there's lots of other ways that I can pull up information. So if a woman's done a My Pregnancy Notes referral, Helen and Emma have processed it, they've put you in for the booking appointment, you can look at your bookings to do. You can look at your appointments for today, tomorrow, next 3 days, your women that have delivered. And you can also look at the workload for your team. So team assigned women, team assigned bookings. And then this one down here that we're going to use later for postnatal triage, all discharged women last 24 hours. So if I click that one, and then I go for postnatal. Okay. So we don't have any discharge any women in the last 24 hours, otherwise that would have pulled up, but we have discharged women in the last 7 days. So that's the function that you're going to use for postnatal triage, but we'll talk about that in a little while. And then reporting down here, this is not one that you're going to need to use very often, but K2 has got incredible reporting functionality. That means any piece of data that's entered on the system can be used essentially as the basis for a report. And you can pull those in like 5 minutes off the top of your head. So there is the argument going forward that we can do much better research on the interventions that we're planning and changes we make to the system, because we can look within our own cohort of women. So, I mean, just as an example, if you want to know, you know, that threshold for steroids, do we want to do 32 weeks, 33 weeks, 34 weeks? We can go in and look precisely at historically when we gave women steroids and what the outcomes were for baby and whether that actually worked for us. So in terms of service improvement, it provides massive opportunities. Okay, any questions about the doors? If not, we'll get on and do a booking.
I don't necessarily have a question about the doors, but where it says obviously you get the booking referrals and stuff.
Yeah.
Obviously, if you're on leave, does that have any impact on this system, or will admin know not to like give you bookings? Will it just work separately, or
yeah?
Does that make sense?
Yeah, admin staff should have an understanding of whether you're working or whether you're not. That's a good question though. And the other thing you'll hear from me today though is I'm going to write that on a post-it, because I have 45,000 post-its that currently run my life, because that is things that we need to build into the process. You will hear me as you go through, like I know how the system works, but I don't make the decision about how the system should work. So I just really want to hear your feedback essentially and your ideas about how we do this in a really sensible fashion, because the tech's really clever, but if we don't lay down a process that actually works for you guys doing it every day, then it's going to fail. So no stupid questions, please. If it's a question for right now, brilliant. If it's a question that you have over the next couple of weeks, then like my inbox is always open to you. Please send me a message and see if we can work out the best way to adapt it to what you see on the ground.
My other question then. Oh, go on.
Oh, go on.
Sorry,
Amy finish. Go on. Let Amy finish.
So with the teams, when we can go into like our caseload that you've just shown us, do we get alerts when a new lady is added, or is that something that we just have to like refresh and be like, oh, I had 50, now I've got 54, say, or will you keep track of it because you'll know the bookings that go into it? Do you know?
You don't get an alert as such. So you're talking about new women that have been booked that have been allocated to your caseload?
Yeah, so say someone else did the booking and then they come over to you. Now we obviously we'll ping an email, or we'll we'll get the green card so we physically know that patient is there.
Yeah.
Obviously you've got it all in front of you, that's amazing, but you might not notice as much if you're getting like 4 bookings in a week, new patients being added.
So this is I hope you're taking notes, Fee. This is a question that we need to work out with community midwifery. It's one that's come up a few times. We need to build in a process where we review the numbers that are going into team caseloads, just to make sure that those are appropriate and manageable and that they're going to the right midwife. But what we'll be able to do is we'll be able to use reporting to look at all bookings completed in the last week, to see where they're going, to make sure they're appropriately allocated. Somebody else had a question.
Oh yeah, I've got a quick question about well, loosely connected to the doors. So you've done your risk assessment. She's low risk for a VTE, and then she gets diagnosed with preeclampsia, which means she then needs Clexane. Would the computer tell you that she was then high risk for a VTE, or is that still human having to figure that out?
So what you would do is presuming the place that you're going to pick her up for that change in her pregnancy is during routine antenatal. When you do the routine antenatal consultation, it pushes you to go through whether you need to do additional risk assessments. VTE would be one of those that you would then pick up, and then you could put a referral through for a Clexane start. So we'll see a bit more of that as we go along. So it doesn't necessarily go, she's now high VTE, so you need to consider Clexane. but it does document that additional risk. It doesn't do the whole journey for you, but it just tries to put you in the right direction.
Okay, cool. Thank you.
So let's do a booking. So let me choose me a patient. So let me choose. Right, I'm using Daisy Cox, and I'm going to shout really loudly that her name's Daisy Cox, because I'm going to go back out of it, and other times during the week I've then forgotten what patient I'm using, and then people in the room have to remind me. So I've written it on a post-it, so it should be fine, but still, Daisy Cox, just saying it out loud. Okay, so Daisy Cox doesn't currently have a booking on the system, so it's going to give me this. Would you like to book and create a new pregnancy? I'm going to say yes. Okay, so as I said, because it's in test, it doesn't necessarily at this point have all the things that it requires. On this screen, it will pull through information from IPM. So it will have all of her names, her GP, her phone number, those sorts of things. And as a point on that, IPM is the single source of truth. So if her address is wrong, or her phone number is wrong, or a GP is wrong, you need to get that amended on IPM. And then overnight, K2 will update and bring those details in. You can't amend it directly in K2. So then we're going to go to booking overview. So literally, this is the process that you follow. You just go step by step by step through the screens. In booking overview, up here is where admin could schedule the appointment for you. So it would appear in your lists. So just for the sake of filling in the screen to show you, we're going to say it's now. It's with a community midwife. It's in community. She doesn't have any special considerations. And so we're going to start with the first box over here, which is her personal profile. And so the booking appointment is now, she's going to be booked at a children's centre. The choices booklet seen prior to booking appointment, yes, and that's going to be in electronic format. So one of the other things that I talked to you about earlier, My Pregnancy Notes. So My Pregnancy Notes, the patient-facing portal, it brings together the ability for the woman to look at her notes, to look at her pathways, to look at all of her appointments, but also it's got some integrated public health advice. So things where at the moment maybe she's using Baby Centre and she comes in telling you that her baby, I don't know, is currently the size of a plum or whatever, all that sort of function is included within My Pregnancy Notes. So the intention is they can come to a single place to find NHS verified information. We can also add local information in there as we need to. So this one, I need you to go careful on this one, please, guys. So this question is about the payment by result stuff. This is about which hospital trust is entitled to claim the money for this pregnancy. So the K2 system in booking and intrapartum and postnatal discharge is currently being used by Chelsea and Westminster. They're not using the full system, just portions of it. They've really struggled with this bit because where it says previously seen this pregnancy, what it wants to know is if a different hospital trust has looked after them. So if they, for example, have been through EPU for a scan with UHP, then the answer is no, because that's care with us. If they've previously had care with Torbay and now they've transferred over to care with us, in that case, it's yes. And then you would add the previous provider down here. But if it's just they've been seen by UHP services, the answer is no, please. No, and we are the lead for intrapartum. If you look after a family who are going to deliver at Trelisk or whatever, you can identify that over here. Intended place of birth, you need to tell it that's Derriford. And then the type of place of birth. So for example, for her, let's say she's going for the obstetric unit. Any details about anyone accompanying the woman. And this is her personal profile demographics. This will be pulled from IPM, but it does prompt you to re-enter the phone number to make sure you've got the correct details. And then, so any issues around language? English is first language, yes. Speaks and understands English, yes. No difficulties. No difficulties with this or this. Doesn't require assistance. And assistance required when completing forms, no. So for the purposes of running you through the system, I am going to book this woman to be pretty much as low risk as she can possibly be, so that you're not spending a huge amount of time watching me click through screens unnecessarily. But that's some of the reason for the time this afternoon, please, guys, to go in and play with different ways forward as to what it does and how it works. And so maternity contacts. So this section is here for other people in the health system. So this will not show to the patient. It doesn't show on the patient's facing side in my pregnancy notes. But this is here in case, I don't know, Debbie Coker wants to go in and see which midwife is looking after this patient. You can go in here and you can add appropriate contact details, phone number if you think that's appropriate. Okay. You could also potentially add things in here like a social worker if you happen to know their contact details. Okay, so because we've done that next section, it's opened up all of these buttons. So in terms of how this morning's going to go, just to let you know, I usually get probably as far as obstetric profile and then we go for a break because it's a lot of information. And then we come back and we do the rest and we do postnatal triage. So just to give you an idea of how much you've got to get through. Then we're going to do pregnancy profile. So date of contact is today and she's being seen with a midwife. Let's be aspirational and say that we have seen her before 10 weeks gestation. No vaginal bleeding in this pregnancy. She hasn't been to EPU. She didn't have ultrasound before booking. We're presuming there's only one. This bit down here is if, for example, they have been through EPU or they have been for a private scan and they turn up with a copy of the ultrasound report, you can scan it and attach it there. Details about the LMP. Let's give her that one. And she's sure of her LMP and it's normal. This is usually 28 days, that's 5. No details of contraception. EDD by dates. And it's going to calculate the gestation for you. How exciting. You've agreed the EDD and you're going to go next. So in this situation, we've said we booked her for 10 weeks, but actually the EDD we've entered says that we haven't. So just some information here about why she wasn't booked in time. So perhaps unaware of pregnancy. Folic acid advice. And she started taking when pregnancy confirmed. And I'm going to give her a normal BMI, so we're going to say 400. You have talked about vitamin D. Started taking now. No fertility treatment required. However, I do encourage you when you go in to play with the system to have a look through the fertility treatment screens. So if you click yes to them, it does open a whole wealth of information that we're not collecting at the moment. It's quite interesting. Okay, and relevant others. Woman has a partner, yes. He is the father of the baby. He is next of kin and he is emergency contact. And we're going to use the same address. So that will just pull through the information that is already saved for the woman. His date of birth. And some details around him. So employment status, ordinarily resident in the UK. So he's not stated his religion. He doesn't have children from a previous relationship. If he did, you can enter those down here. He doesn't have social or mental health issues. He doesn't have learning difficulties. He can be white British and they're not related. Okay, so you've worked yourself through another one. So as you can see, these are now filled on here and they're filled down here. So you can see how far you've gone. Social profile. So his ethnicity, oh no, ethnicity for her, white British, again, religion not stated. Residence in the UK, ordinarily resident. A point about this one, the NHS eligibility form, I wouldn't anticipate you entering any data for that, because if you say yes, it wants you to provide a copy, which if you have it, brilliant, but the majority of women don't have those. Let's say they're cohabiting. She does feel supported. She has permanent accommodation that she owns. And let's give her a degree. And that one. She's employed. She's not entitled to claim benefits, and she doesn't require advice on finances, benefits, or housing issues. And so let's make her not a smoker. However, if you select current smoker, it does open up the other screens so that you can collect more information. But we're going to say that she's not a smoker and nobody at home smokes. CO testing, so enter that there. We're not referring her to smoking cessation. If we had said she was a smoker, it will open up these buttons down here about smoking advice that we're going to offer. Some bits and pieces on pregnancy. Oh, sorry, on alcohol in pregnancy. We're not going to refer her for alcohol misuse advice. No alcohol concerns for the father. And no history of drug use for her. However, if you did select current user, it does open up those screens for additional information. And we're not concerned about this for her. Other complex social factors. So what I would expect is you could note those here, but if you did have safeguarding concerns, you would need to run the safeguarding screens in confidential mode, and we'll do those in a minute. So for the purposes of her, let's say no. And that's another one done. So medical profile. So you're not probably going to know her blood group at booking. If she was a multip, you might be able to look it up on ICM, but if you don't know it, then you can carry on. Rubella status not known, whether she's got any history of chickenpox. 2010. You have discussed it. Yeah. So here is one of those examples where I was talking about structured data. Amy King, I see your hand.
If you miss bits out, so you don't complete a box, does it prompt you to go back in? Like, will it not complete the circle a bit like the e-learning we do, or will it not? Will it not matter?
It depends on the data. So some of the data is mandatory. And if it's mandatory data, it's because we need it for national reporting or local guidelines. So if it's mandatory and you haven't entered it, it won't let you move to the next screen. It will say you need to go back and update this. But if
so
you
just do all the boxes, but it won't necessarily always stop you from going on to the next one.
Yeah.
Cool.
So the other thing that you might hear me talk about are wizards. So each of those things we've been going through, I've been clicking a box and it's pushed you through a certain set of screens. Those are wizards. So you don't necessarily need to enter all the data in the wizard, but it won't let you complete it unless you've entered the mandatories. So as I said, this is one of those places where if you enter this information, it's structured data that goes to other places. So if, for example, we decided that this lady's diabetic, I know she's been low risk up until now, but if we select diabetes, she doesn't have any of those. History of diabetes, yes, and she was diagnosed in 2007, let's say, and she had type 2 and her care is by the hospital, and she has metformin, let's say. And then next. Okay, so these are one of the mandatory referral boxes. So we'll talk about referrals in a minute. But the way that women end up behind a door for a referral to pick up for additional care, it's either because you manually put a referral through, or because the system is tied to certain elements where it knows that that woman needs a referral. So here you've got the big yellow box. Would you like to refer to diabetes endocrinology for history of diabetes? So answer me a question. What does our current diabetes referral pathway look like? If you come across a woman that hasn't been picked up already into diabetes care services and you book her, what do you need to do?
Email antenatal clinic.
Yeah. How long do you reckon that takes, filling in the forms and getting the details and processing the other side?
Fair amount of time, I suppose.
Do you want to see how long it takes in K2?
Absolutely.
Read that. Completed it, done. That's her referral in place.
Fran,
Yeah.
who picks that up the other end then to make the appointment?
Antenatal clinic admin.
Okay, cool.
We'll go through how that works in a minute. And I'll also show you how to check in on referrals and to make sure that your referrals have been processed. So complications of diabetes, none. Planned pregnancy, yes, she did get preconception advice. We didn't do that though. Doesn't have any known allergies. And then the mental health assessment. So I need mental health assessment, please, at every community interaction. So whether that's antenatal or postnatal. So consent obtained for mental health assessment. Again, I'm going to complete the screens for her to be quite just straightforward. No anxious edge, not at all. Fine for this. Doesn't have 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 this. Haven't been able to look at the GP records. Can't get any information from there. These are screens that are for the health visiting team. So please do fill these in to give some details about the conversations that you have with women about their pregnancy. We're not going to refer for trauma and birth fear. And she doesn't need a mental health referral. She is up to date with cervical smears. Her result is normal. She hasn't had any treatment and she doesn't require a postnatal smear. Nothing for this. Nothing for this. And then medication in the last 6 months. So please review medications via the pregnancy toolbar before answering the following questions. I'm going to say yes, and then I'm going to show you where that is. So that is in relation to our little buttons up here. So if you remember, this is our Rockenden button that I desperately want you all to press at every situation. She hasn't had a risk assessment yet, so it's grey. The booking wizards do push you to go through that, so I won't do that now. This is her medications tab. So if she was taking any current drugs, so maybe she's taking, I don't know, what might she be taking? Maybe she's taking some cocodamol PRN. And that's ongoing. So those now appear up there. This is your referrals button. So you see that diabetes referral that we press the button on is there. So you can go in and you can look at it. And you can see it's been made, but it's not been accepted at the current time. And any completed referrals would sit on this side. What I need to encourage you to do, please, is use the other button, this actions button. So whenever you complete a referral, I also need you to add an action, please, so that the person going in to process the referral knows what you need. So you've put through the diabetes referral. If you then add an action to say arrange appointment, so woman type 2, and ongoing care pathway. Target date is today, and you're going to assign that to admin, and that's pending, and then finish. So you now know that she's got an action up here. So whenever you see a woman for an appointment, if it's routine community antenatal, it's going to prompt you through the outstanding actions and referrals anyway. But just as a heads up, that's what that means. This woman requires something in some fashion. And so what will happen is antenatal clinic admin will pick up those referrals, and then they'll use the action that you've set to make sure that they're doing what required. Okay, so obstetric profile. I'm going to say no to first pregnancy with a new partner. Here, there's a bug that won't let me save previous pregnancies at the current time, which is not really helpful. But I'll just take you through the screens. So it gives you the opportunity to enter previous pregnancies. No antenatal conditions for her. She had a spontaneous labour. We didn't augment. She didn't have anaesthetic. Yes. And she had a vaginal delivery and no issues with delivery. And she had active management and everything went well. And she was all right in the postnatal stage as well. So in a minute, it's going to say cannot save, but that's just a bug in the system. And so child details, live outcome. See, again, this is structured data. So because I told it before it was an SVD, it's going to pull that through. And she delivered in the hospital. That was female, breastfed. This is helpful as well. So, you know, when you say to them, how much did the baby weigh? And they go, oh, £7.12, and you have to do the calculation. Not anymore. And no postnatal complications for the child. The child's alive and well with the mother and new partner in this situation. Right. See, this is the error message, but you won't get that. I'm going to come out of that. Okay. So what we're actually going to do for the purposes of needing to complete the wizard, I'm actually going to say it is a first pregnancy. And then it will give you details here. Doesn't need Coney referral. And then that one's done. So family history, we'll push through these last two and then I'll give you a break for a minute. So woman's family history known, yes, no. Father's family history known, yes, no. But there's no relevant conditions. When you go through this wizard, it is going to say to you at the end whether you want to raise a referral to the screening team. But just as an FYI, the screening team are going to have customised reporting that they can run daily, weekly, however they want to run it. So anyone that has risk factors, either indicated here or anywhere else in the system, that they think might require screening's attention, they're going to pull them directly. So that's not to say that you shouldn't put in a referral for the screening team if you think the woman needs it, but they do have that oversight as well in case it's something that you potentially haven't identified as something that needs attention. Okay, again, structured data, you've pulled this through from elsewhere. There's no concerns in the mother's family or the father's family. Partner doesn't have a history of mental illness. No issues with tuberculosis. And I'm going to say no to a referral to the screening team. And that one's done. And then we'll just do this screen. So this one is about data protection. No, this is about public health advice. So you can just press this button to say all information provided, but please do just take a look at what you're clicking there to ensure that you are covering everything that you're saying you're covering, because your patter might well be off versus what the system expects you to collect. So have a look at that one when you've got a bit of time later on. Again, information provided. This one, for example, you're probably going to say no to this one around blood transfusions. Vaccine offers, you don't need to document anything in this in the booking process. If we, for any reason, offer her vaccinations, I don't know, through DAU or ultrasound or whatever else we might be doing, that's where these are going to be documented. If she's going to just get them from her GP, you don't need to make an offer of them. It's only if UHP are going to be delivering those. And do you know what? I might just push through so then we can have a bit of a bigger break. So observations. So that's all of our history that we've generated there. And if we were going to go back through into the other screens, all of that information about the history is going to sit behind all those tabs in all those other places that we showed you except previously. If you do observations.
Fran, did they get a link to then that public health information on their screen? So we're saying, yes, we've just discussed safe preparation of food, foods to avoid, and then they can access that information on theirs. So we can like refer them to it.
Yep.
Cool.
It will be available via electronic leaflets in the information section of the patient-facing portal.
Perfect.
And it's mostly links to national health advice rather than our local advice. I'm trying to avoid local advice to make sure that it's as up to date as it can possibly be.
Yeah.
But yes, they'll be able to go to the portal.
Perfect.
So time of observations.
Francesca, are those leaflets available in different languages?
Oh, that's a really good question. Don't know. I'll write that on a post-it. If we have them nationally, then we can add them.
Okay. And what about people that can't access their devices all the time because they run out of credit and things like that?
Yeah. So we do have some money in the kitty to provide people data SIMs to support that access. As a point on that, about a year ago, I did a patient access survey. I spoke to 300 patients over the course of a week that I gathered either from surveys going through antenatal clinic to make sure we got a broad cross section. I also made a lot of phone calls, including appropriate sampling of the Sycamore girlies. And also I did English as a foreign language via translation over the phone. Of the 300 people that I spoke to, only one of them identified themselves as unable to access the system. So I think it's going to be a small percentage, but where we do identify those women, we do have things that we can do to give them either, you know, devices or data SIMs or what's required. If they feel that they cannot access the online system effectively or they don't want to, then we can just print them and give them paper records. And that's part of the conversations that we're going to have in a minute in another screen.
Okay, thanks.
So observations now, we have measured the blood pressure. We didn't use a large cuff. Use 120, 80, manual, and 72. No edema. Did do a urinalysis. It was an MSU. Urine was NAD. I have sent it for MSCNS, but I haven't sent it for PCR. I haven't palpated the abdomen because it is not routine for this gestation. I haven't listened to the fetal heart because we're not there yet. I have discussed fetal movements. She hasn't felt them and there haven't been any changes in the pattern. I am going to calculate her BMI. So let's make her and then that one and that one. Okay. And then we're going to finish. So a point on this one. So if you are booking a woman over the phone, so you're not going to be able to do her blood pressure, MSU, height and weight, whatever, but you're putting her into a clinic for bloods where the person that sees her there might be able to do it. What you could do, or I would ask you to do, please, is to add an action. So we're going to do add an action, provide information, description of action. Please do BP and MSCA. And then whenever you know she's going to be seen, so you've put her in for bloods for next week, and it has been assigned to MSW, ending and finish and save. So that means when she is seen for bloods, there's a little trigger on the system saying, please, can you make sure that you add that information? We'll do the last two screens, and then we'll stop. We're going to do investigations. So these are offering screening. If you are going to go that route, you can just go all explained and offered and all accepted. On this one, go careful, please, because you can click all explained and offered and all accepted, but it does have random glucose, which is not one that we're offering as a trust. So you need to say no to that one. And then here, all explained and offered, all accepted. But again, rubella susceptibility, you're going to say no. Offers made by me. And then it wants to know why I haven't offered a random glucose. And that's because not currently offered by the trust, and same for rubella. And then this one's slightly different. So if you see them face to face and you make the offer and you take the bloods, you would fill both screens. All ordered, all taken. And so ordered means that you put them through an ICM. So in terms of the way that K2 and ICM play together, so results that are on ICM will be automatically brought into K2. And you will need to go in and review them. Once you've reviewed them and actioned them, they will be viewable by the woman on the patient portal. But you do still need to go through the process of ordering them. So in community at the moment, that's still going to be via the paper forms until we get the printers out to you. But yeah, so that's what it means. That's the difference between the offer and the order. So you might well be making the offer, but if they're then seeing the phlebotomist, it's them that's going to do this screen of all ordered and all taken. That's going to be by me. Okay, and then we'll do this last screen before we stop. So this is about online notes access. So this is the conversation. This is the data protection one, just making sure they are happy to use the online portal. And if they're not, having a conversation with them about how they want to access their information. So if they don't want to use the portal for whatever reason, are going to struggle to use the portal, you can provide them paper notes. We will still use it clinically on our side, but they don't have to if they don't want to. So you just need a yes or no in there. And then we're going to stop before we get to the next bit. I'll give you a moment for a coffee and a wee or whatever it is that you need. Any questions about process or the system or anything that we've covered already?
I've got a little list, Fran.
Yeah, go on then.
So first one is just, we can have a conversation about assigning patients. I just think for, as in caseload sizes, Amy, I know you mentioned it just now, but I think this will be really good because I think some of you have caseloads that are just like ridiculously big and others haven't. So I think that that could be quite an easy fix in that we get Helen and Emma to very easily look at caseload sizes and think, or actually, Amy's got a caseload of 120 and it should be 60. So we don't give her another booking, or she does a booking but allocates that to Fee Tunnicliffe because Fee's only got 45. And it will just be much easier to see caseload sizes and distribute easier. So I think that will be a really easy fix.
The other sorts of things I can do for you, Fee, just as an FYI on that, we will have a conversation outside of this room, but I can build you detailed reporting that sort of says this midwife has got this many patients currently on their caseload, but I can also break it down and go, actually, do you know what though, 75% of her caseload is CLC, so they're probably actually quite heavy, whereas that one, like she's got what appears to be a larger caseload, but 90% of those are MLC. So you can properly look at the workload breakdown that each person's got.
Yeah, that's good. Fran, just, and the girls will probably know this anyway, can we amend addresses or any data on IPM, or does that still have to go to?
You can amend addresses, you can't change GP. So GP would have to go to the admin team, but addresses and phone numbers you can change.
Okay, that's good. Overseas, so there was a button there. Does that go straight to if they're not eligible for NHS care, or we're not sure, does that referral when you click the button go straight to our overseas team?
No, you'll know if it's an automatic referral because it will do the thing it did for diabetes where it comes up with that yellow edged screen. Those are the automatics. If it's not automatic in the yellows, then you have to put through the referral to put them behind the door.
Okay, so is that a ridiculous question? Excuse my my absolute IT illiteracy.
Yeah.
Is there an overseas door?
If there isn't, I'll make one. I'll put it on a post-it.
And then, so they go behind the door and that'll get picked up by overseas?
Yeah, exactly that. Yeah.
Amazing.
So anyone with a Derriford network account has the ability to look at K2. They can't document in K2, but they can look at it. So it means that referrals that need to go to other parts of the hospital, we can organise because they can go and pick them up out the door.
Good. That's good. Because that'll save another
Mhm.
phone call and another email.
Yeah.
I did obviously have the question about no phones, no internet, but you've sort of answered that.
Yeah.
The bloods thing where you said you can do an action for like one of the MSWs. I don't think they're on the training.
They are.
Are they all on the training?
Yep, they're doing postnatal outpatient. They're not doing this bit, they're doing postnatal outpatient. But at every point of training along the way, we talk about referrals, we talk about actions. And for them, there'll be notes in the training plan about picking up on actions that you might get from booking.
Okay, so our MSWs don't routinely do the bloods at the minute. So
Fine.
when Lauren comes back from maternity, so do you know what just makes me wonder whether we utilise Future In a little bit more, because if you've requested bloods and that then goes over to ICM, they can all just go up to Future In.
At the moment, that's what I was saying, that order doesn't go directly to ICM. So the results come back from ICM, but the order doesn't go to
sorry,
ICM.
I thought you said it does go directly to ICM.
However, there is the other piece of work that we've got the okay for that Michelle's doing at the moment about getting the printers into community midwifery. So once we've done that, which we're just waiting on deployment for, then we can send them to Future In, because the order would be done on ICM routinely for community midwifery. So that is in the bold near future.
Fab. Confidential pregnancy, can I just confirm? Previous pregnancies, you can press confidential and that will just come up on our confidential information. Love that feature. And I also love the alcohol feature as well, because I used to have to get my alcohol thing out, but love that.
This project is sending me to alcohol, but that's a different story. That's fine.
Well, at least you know how many units you're having, Fran, because there's a pretty picture to tell you.
I don't think I want to know. Has anyone else got any questions before I send you for a break for a bit?
Quick question about the EDD.
Yes.
So you put it in, and then one of the questions was, do you agree this EDD? Yes. What happens when they change it at scan?
So scanning is a bit of an interesting one. I'm going to stop sharing for a minute so you can look at my face. Scanning is a bit of an interesting one because they use a piece of IT called Viewpoint, and Viewpoint lives on a server from about 1965, which means I've not been able to integrate Viewpoint into K2. We might do that at some point in the future, but not yet. So what I'm going to need to ask of Sonography, there's about 6 pieces of data that are mandatory for MSDS returns. So they are going to continue to document on Viewpoint, but I do need them to go in and update just these things to make sure that we're completing that information. EDD is one of them that they will need to go in and look at for me, please. Other point about the fact that Viewpoint's not integrated, and we'll talk about this a bit later in community midwifery, about looking at the scans. So if I'd been able to integrate Viewpoint, it would all come over automatically, but I can't. So what we're going to do is, at the moment, they generate that scan report and they print it and they put it in the woman's notes. Instead, what they're going to do is they're going to generate a PDF and they're going to attach it to the woman's K2 record. And I'll show you this afternoon where you need to go to be able to look at that.
Okay, thank you.
All right. Any other questions that are burning in your bones? No. Perfect. All right then, shall we wander off for 10 minutes? Should we come back at past? And then we're going to do risk assessments, management plans, care pathways, and how to complete the booking. All right then, guys. See you at 12:30.
Thanks.
Oh. The antenatal inpatient sessions started today for those of them that did bookings last week. So I just dropped into that to see how that's going. They seem to be quite happy. Please, if you're back, can you just pop your hand up for me so I can see that you're back so that we can do the next bit, if that's all right. Yay, cool. All right, so you can take your hands back down now, thank you. Before we smash back into watching Francesca click through loads of screens, I might talk to you a little bit about offline mode. Because we need to make some decisions about how we are going to use this particular part of the system. And Fee, I'm really interested in your thoughts in this. Obviously, everyone's thoughts are more than welcome. So I'm going to share the screen for a minute. I'll show you something. So if I go back and I go into my desk and I look at my assigned women. So K2 has this cool thing called offline mode. And offline mode you can use when you don't have internet access. So if, for example, you're working at Reece, and we know that Reece has got decent access in the office most of the time, but in the clinics, it's poor in the clinic rooms. So what you can do is you can put your women in offline mode. So that's literally, you go into my desk, you choose the women that you want. So it might be my appointments for today. I haven't got any appointments scheduled, so I'll just use my assigned women. And then you go offline mode. And so I'm going to display my assigned women. And then what I can do is I can choose the records that I want to put in offline mode. And you choose what you want, you drag it over, you sit them on this side. This little screen comes up that tells you that the system is putting these women in the briefcase. So this is the thing I mentioned earlier about putting women in the briefcase. So now these ones appear on this side. If you're using the offline briefcase, you need to make sure that auto sync is switched to on, because that means that whenever your laptop is near an internet connection, it will automatically add information that you have entered to the main record. If you were going to see these women in a situation where you had no internet access at all, that wouldn't happen. But if you did that and then you got your laptop to somewhere it had an internet connection, as soon as you opened it and logged on, it will go back and it will add the information to the main record. So then I've put my women in the briefcase. I'm going to go start offline. I'm going to log back in. So now it doesn't give me all the other shenanigans. It doesn't give me the doors. It doesn't give me the wards because it doesn't have access to that. It's just the ability to document in these records. And so I can go in here and I can view the woman's notes. It's going to let me, and then I can go in and document that way. So whether I've got internet access or whether I haven't, I can still document in there. And if I go back, once I was done, I could end offline. I'm going to log back in. And then what I could do is I could go remove from the offline briefcase. So that means I'm not carrying her around anymore. And they're back in the system. So I'll stop sharing. So we did an activity week before last, which is a structured risk workshop for the clinical safety case. What does that mean? Amy, I see your hand.
Hi, just a quick question. If they are in your briefcase, does that mean that nobody else can access that woman?
Well, so this is part of this conversation. So we did the clinical risk workshop for the safety case, and so the safety case is the governance work that we have to do to get the trust to sign off to say that we have considered all hazards associated with the use of this system and we've mitigated the risk as much as possible. So there was quite a long conversation in that workshop about the briefcase, because one of the hazards, of course, is what if we lose network access? What if we lose database access? How do we continue to effectively document on these women's records? So one of the arguments made was, so actually a bit of context. So if we lose internet access to Guardian, so if we lose access in the intrapartum episode, that access is fairly consistent. It just starts running off the portal rather than off the main network, and it will continue to document in there until we get internet access. So for Guardian, not too much of a concern. If we lost network access, we would lose central monitoring, which is sad, but everything else would be fine. Athena, though, is a bit more of a difficult beast. So if we lose internet access to Athena, you cannot document in the record. So then your business continuity is to return to paper. And so a couple of comments that were made about that. If you're then running community on paper, one thing about, if you look at the current paper notes, they're quite structured and there's prompts for documentation. Are we doing midwives best service if the fallback plan is continuation sheets? Because you haven't got that structure to prompt to make sure that the documentation's there. I'm certain that midwives would know what to write, but it's about giving, you know, the best environment possible to make sure that we can do our jobs properly. So then if you do go to paper, do you have to have photocopies of the existing perinatal notes available in all the locations so that you can use them if you need to? And then the question about data backfill. So if you look at EPMA, for example, which is electronic prescribing in other parts of the trust, if they lose the system and they have to go to paper, there's then a piece of work afterwards where clinicians have to go back through and transcribe to make sure everything written on paper goes into the electronic system. So how do we build that into the process? So the discussion was had of maybe we routinely use the offline briefcase. So at the beginning of the day, you put the women in the briefcase, you document on that record through the day. As long as you've got auto sync switched on, if you're in an internet environment where you have got access, it will continually take the records up. If for any reason you don't have internet access, what happens is if somebody else tries to document in that record, it says this woman is currently sitting in an offline briefcase. And so you might not be able to see the full record of information. So the benefit is you always know that you're going to be able to document electronically, but the risk is what if they get left in the briefcase? And so we also use offline mode if you've got a home birth in a difficult location, for example, where you haven't got internet access. And other trusts have had situations where midwives have potentially like gone to a home birth overnight, knackered, come back to the unit in the morning. They haven't taken the woman out the briefcase and then they've gone on annual leave for 2 weeks. Like that's a situation that's actually happened. And then the woman's intrapartum record is sitting there for a fortnight without the ability for it to be updated. If you know, the midwife's gone to Barbados, you can't do anything about that, has to sit in the briefcase. If she's left her laptop behind though, which is nice, anyone can log in to that laptop and update the record because it's stored locally rather than specific to that midwife's profile. So yeah, this was just a conversation that was raised. It was quite a long discussion, and we need to have a conversation as a service about what is the safest and most effective thing to do. So I've been putting it to teams whilst we've been doing this training. Fee, I see your hand. What do you reckon? I think you're on mute, mate.
Yeah, I think the online briefcase is great. I think we've managed to upgrade our internet across Plymouth. We need to get funding for Cornwall because your Tor Points, your Lou, Amy, I don't know what Callington's like. It's probably good, isn't it? Because it's a clinic, proper clinic. But I think there's quite a few areas that still don't have you know, so I think using an offline briefcase is good for, you know, just on the odd occasion. But I feel like there's probably going to be some areas that will need to use that as routine, and that's where the problem will lie.
Some of the thought in the risk workshop was that if we build it into standard routine process, that's what you always do, regardless of where you are, with online sync on, so that if you have got internet access, it's fine, is that you've then got less chance of women being left behind. If it's just a basic thing that you always do, people will get into the mindset of taking them out and putting them back. If you leave it to, oh, you use it if that's what you think that you need to do, then you are generating more chance of women not being moved back to where they need to be. Do you see what I mean? That was the logic under discussion.
So everybody's going to work offline. Is that what you're saying?
Well, this is an option. This is what came out of the risk workshop from, and I have all sorts of people in there that do like clinical safety and risk, like across the trust. They're not saying we have to do it, but they're saying it's a conversation that we should have about whether it would be better just to set a routine process where all records are moved into the offline briefcase for community midwifery as standard, rather than doing it on an off-the-cuff basis. And also then, if we always do it, if we do happen to lose internet access at, you know, midday unexpectedly, those records are in the briefcase and you can continue to work that clinic for the rest of the day.
And how long does that take to put you in? It takes 2 seconds.
I literally just did it on the screen.
Okay. Great. We need to sort out the internet, Fran. We can't have electronic records and not have internet access for some staff.
Yeah. So if we did routinely use briefcase mode, if you could hotspot off your phone for 2 minutes to be able to bring the record over, you could then work in those records all day and then hotspot off the phone if you don't have access for 2 minutes to bring them all back at the end of the day.
ListGuard's a perfect example. You can't hotspot. So no internet because you're Cornwall, and you can't hotspot. So do you see what I mean? So
yeah, it's an interesting one. We need to balance one risk off against the other and make a decision about what we're going to do. Amy, I see your hand.
Sorry, going on the offline thing, which it sounds like a good idea with the internet issues, but if my question is, if you've got a lady who is due to be seen in clinic and then turns up in triage, we wouldn't be able to access her notes because she's in somebody's briefcase. Would it tell us whose briefcase she was in so we can give them a ring and get them to take her?
Yes and no. So it would not show you specifically whose briefcase she's in, but you would be able to look on the system to see whose clinic she's in that day. So you would be able to know who's due to be seeing her. And also just a point about the record. So in that situation, so she's seen in clinic, you know, midday, and then she phones triage at 3 o'clock. If she was still in the briefcase at 3 o'clock, you would be able to see the rest of the record, but you would not be able to see the midday antenatal consultation. So
I see.
Would be there, but it would be just the data from that antenatal consultation that would be missing.
Okay, could we then, so we wouldn't see what had happened at 12, but she could probably tell us, and then would we be able to amend it ourselves so that when the briefcase was emptied, it all just kind of went back together? And all right, cool. Okay, thanks.
As soon as the briefcase that she's in, I say it so often and I've got so used to it not being a weird comment, but it is a weird comment. As soon as the briefcase that she's in is given access to the internet again, it will automatically sync and match the record, so that it will come in. And as I said, there will be a flag to say that woman's in the briefcase, and so you might be able to see what's just happened. Amy, I see your hand.
So if they're in the briefcase and we need to, say, refer them into triage, or we need to complete like a scan referral because they've measured small or something, will those referrals still go through as well, or do they need to be kind of like online for the referrals to work?
Exactly. Yeah, it needs to be online. So it needs to It needs to hit internet access to be able to get to the rest of the system. Because when
Yeah.
you're in offline mode, it's literally just the ability to
Just-
look at and manage those records. It doesn't do anything else.
Because obviously, I guess the point in the system is to reduce your kind of overall workload. So you've seen someone, they need a scan, you do it straight away.
Yeah.
You're not doing all these bits at the end of the day, which can then be forgotten. So actually, if we routinely did it offline, that might reduce that kind of productivity in a way, or that fail safe for the referrals to be done. Fine.
So
Good
you
to
can
know.
still generate the referral and it'll be sitting there on the record. And then as soon as the
Fine.
record is active again, all the actions associated with that record will kick back in.
Fine. So it will still work the process. It just won't have gone through until the internet. Okay, that's cool.
Okay. That's probably a long conversation to continue to be had. But also, so just as a point, I sort of briefly mentioned home birth there. So home birth for is done on Athena if you're away from the unit, because Guardian, the intrapartum module, runs on the portals. So if you're doing a birth at home, you'll use Athena on a laptop, which means that I've got to add 2 laptops to the home birth kit, so not just 1 but 2, just in case one decides it's going to have a paddy. Apologies for putting that more stuff in your boot, but just as an FYI, that's how that's going to work. Okay, so let's bounce in and do a bit more. The other thing I didn't say earlier that I meant to say, in the video, it said, please make sure that your username and password are set up. For clarity, your username and password are your usual usernames and passwords for the network. So whatever you usually use to log onto a PC, that's what you'll use for KT. Okay, so I come back out the briefcase, so I'm back here. And I'm going to go search for my patient. So when we went in before, we went via the quick tiles to pull her up. Because I've already started working in the record, I can search her, and her name was Susie Cox, right? No. Oh, I wrote it. Daisy Cox. Wrote it on a post-it. Post-its come into play this time. Daisy Cox. One of the questions that I've had from a few people is about whether we can do the thing that we do at present for some, or some people do at present, where they start the booking in Salus and then they go back in when the woman's in the room and fill in the rest of the details. If you wanted to do that in K2, this is how you could do that. So we've been in, we've filled in some of the information. You can then go back in and search her record, confirm that it's her. And then in profile, you have to go back to, or in consultations and admissions, excuse me, booking, you have to go back into booking overview to get us back to where we were. So we've done all of those bits. And so then you've got your risk assessment. So I'm not going to walk you through every single risk assessment because they're wizards, as we've done previously. They push you through the steps. It's an awful lot of sitting, watching me click through screens. So this is again why I'm giving you time this afternoon to play with some of those risk assessments, please. But we are going to do one for the purposes of demonstration. And so let's do the VTE risk assessment. And so we're going to assess her now. It's antenatal and it's an assessment by me. She's not currently admitted to hospital. She doesn't have any previous history of VTE, but we did make her a smoker, didn't we? And she is also over 35. We're going to give her 2. These ones, she doesn't have any of these. So you need to click the one at the bottom that says no risk factors apply. This one's new for us. We've not used this previously, but these are ARCOG recommendations. So they're happy for us to use them, but you might want to spend a bit of time familiarising yourself with these ones because you might not have seen them previously. We're going to say no bleeding risk factors apply. And then it's given us a score and a suggested risk status. You can decide that actually you want to give her a different risk. But for her, I'm going to say hydration and mobilisation. and risk status. Leave her as lower risk. Okay. This is a bug in the system that plays intermittently. So I've agreed with the system, but it thinks I'm doing something different. This won't happen in the live system. But this just gives us the opportunity to show about why you think it's changed. To say, I don't know, discussion goes ANC for or something to that effect. So those are your risk assessments, and I'll ask you to go through and play with those, please. The thing we're going to do then is her management plan. So we're going to go down here. So one of the things that I think is going to become different for our practice is, rather than having this one overarching management plan in the green notes on page 26 or wherever it is, because of the level of visibility that K2 offers to information that you're entering, you're going to end up with multiple management plans in all different areas, but that appear in the same place, which we sort of have at the moment. So, you know, she might have a diabetes management plan, she might have a management plan that the consultant's written in the intrapartum section, in all these different spots. But K2 gathers those all into a single location. So if we're doing a management plan for this lady because she's a smoker, for example, we're going to say it's antenatal during an outpatient consultation, and you've done it face to face. And we're going to say she is a smoker for the day. And things that we've done, so she's declined smoking cessation. She is going to be for serial scans. She's going to be CO at every appointment. An example. And then there's a decision for you to make about whether you want to make one big management plan here, you could continue to document underneath, or whether you want to do individual management plans per risk. And I'll explain to you what I mean by that here. So that's my plan for her regarding being a smoker. I have discussed it with the woman and finish. So now when I go into her profile over here and I look at her plan of care, I can see her management plans. So what I could have done here is I could have put this thing, this thing, this thing, this thing all in here together, or I can add individual management plans. So she is quite low risk and straightforward. So say, for an example, she's decided that she's query home birth. So I can add 3440 home and risk assessment, presentation, test, FBC, Victoria. An example. Yes, and finish. So in terms of the way that they then appear, they're all going to appear together. So it's really a decision for you to make in your own practice, whether you want individual plans that you can then go in and edit and update, or whether you want to put them all in together. It doesn't particularly matter because they're all going to appear in the same place. That's your own decision. So I'm going to go back into the booking overview. I'm going to go into profile. Sorry, consultations and admissions, booking overview. So we've filled in all of these screens. I'm going to ask you to go and play with the risk assessments, and then we're going to go type of care. So you're going to make a decision about whether she's midwifery-led care or consultant-led care. So say, for example, we're going to make her consultant-led care. This is one of the things, Fee, that I wonder about what the process we need to run is around this. So we're going to say that she's assigned to a midwifery team. So say she's going to Greenock, but here in the assigned midwife, do we assign them to a particular midwife, or do we assign them for allocation? And then there's a process that we go through within community midwifery to look at where she's going to go. Because I worry if you just assign her a midwife here, the midwife booking is not going to know that thing we're talking about the capacity of the caseloads and the size of the caseloads. Amy, I see your hand.
Sorry, muted. So yeah, my question was, we at the minute go through on antenatal clinic all of those women who are unsure. So at the minute we've got midwifery led care. Sorry, my clock's going. Consultant led care, and then we've got a consultant opinion, and they all go through a blue box, and then it's decided essentially which one they're in. So what would you do about those unknown ones?
So what will need to happen is, because I don't have an unknown, they will need to go into consultant-led care with a referral to put them behind the for consultant opinion door. And then the consultants will do triage as they do currently. They'll go behind the for consultant opinion door and then make a decision about what they need doing with them.
Okay, how do we put, when do you put that referral in?
So I would say that you would allocate them for consultant-led care, because it's better for them to be accidentally indicated as high risk rather than inappropriately allocated to low risk. So I would say you would do that at the end after this. So once you've done this bit, and so assigned consultant team, you would choose placeholder consultants, and then in here you go for comments triage, and then finish. And then after you've done that, you would go up here and you would add a referral. Required referral reason, indicate whatever your reason is. It's in test at the moment, so you might not be able to see it. So testing V6. Yeah, it's not in there yet, but that's where it would be. You would put her behind the consultant opinion door, and then that's where the consultant triage will happen. Just as an FYI, for Go Live, you are going to have like documentation of lists of like, you need to do this and you need to do this and you need to do this, your step-by-steps, and you'll also have process maps of, in this situation you do this, and if in this situation you do this. So you're not going to be in a position on Go Live where you're going to have to remember all of these things. We will provide information for you. Also, in terms of support on the ground for Go Live, digital team are working 24 hours a day for a bit to make sure that we can keep this thing standing up. What you'll have is, for routine every day, like I can't find this bit in the system, I can't find that bit in the system, you'll have a Teams channel open all day with a clinical systems trainer sitting at the other side that you can drop in and go, where's this bit, where's that, and they'll share screen with you and show you. For bigger stuff, if process questions emerge that we haven't nailed down, you'll be able to refer through the champions or community management, or you can hit the digital bleep and one of us will give you a call and answer your questions for you. But Fee, as a comment for you, what we're going to need to do is we're going to need to run community midwifery escalation Teams channel, so that if we need to nail down process questions, whoever it is can drop it in the chat, tag whoever, and then we can pick up and make sure that those questions are answered appropriately. Yeah.
Fran, going back to allocating, I think that we need to get Helen and Emma on board to just be looking at what caseload sizes are like. Because Chelsea and Amy, you'll be the better ones to answer, because Chelsea, I know your caseload is ridiculously big. So you're going to be the one that's going to benefit from something like this. What do you think? Because you can still book women, can't you? But it may well just be that actually when your caseload is extortionate, that you book the woman, but actually you book that woman and she goes to Donna. So you can allocate Donna as her named midwife. So Helen and Emma look and say, all right, Chelsea's got a booking appointment, but her caseload's massive. Donna hasn't got a booking appointment, but she could add another one. So not ideal that you book for somebody else. What do you think?
It's kind of similar to what we do now, isn't it? Like we book for other people, and then we just let them know by email that we've booked them for them. I think Yeah, it's worth trialing,
Or-
isn't it, and seeing if
or-
it works.
Yeah, because Fran, obviously when they go for their scan, then
Mhm,
they're going to be booked in with their named midwife.
mhm.
So if Chelsea books her, but
Yeah.
actually Chelsea's not going to keep her because her caseload's massive,
Mm,
so she allocates her to Amy.
yeah.
That woman then needs booking in for a 16-week with Amy, not with Chelsea.
Yeah.
I think sometimes it does even out as well. I think, say like just my case as an example, because that's all I know about, but lots of people know that me and Abby work there at Whitley, but they don't know who does the other clinic days. So it's not that they're not trying to think and allocate them evenly. It's just they don't know who does the other days. So then they're just like, oh, well, we'll just put Amy and Abby. So whether there's can be some more visibility about who runs what clinics when that's sorted for you. I know that's a logistical nightmare on its own. And then that may help with the evening out of the caseloads as well. But yeah,
Rather
it's a
than
tricky one, isn't it?
booking them with Amy and Abby, but actually putting them in for
Yeah.
I don't know, Charlotte on a Friday instead of. So then Charlotte, actually she's not on Charlotte's caseload. Technically she's
Yeah.
on yours, but she keeps getting seen in Charlotte's. Yeah. I think it probably needs to be clear at booking who they're with and who they need to go in with, because that should have been, if Helen and Emma will have done their job right, then Amy and Abby will have capacity.
I guess as well, personalisation is a point in it, isn't it? Like we offer the women, there's a clinic here Monday, Wednesday, Friday. Do you have a day off work? Which is your better day? Like we do that as well. So it is a little bit. It's not always as simple as who's got the room in the caseload. Let's put
Capacity.
it there. But it would, I think, if we went through and allocated it a caseload side, it would probably even out better, wouldn't it? Don't know.
It's just one of those places where, go on, Faye.
Can you reallocate? You can reallocate. Yeah. That's fine.
It's just one of those places where K2 is going to shine light on corners of the way that we work that we've not been able to see before. Like it's one of those where it generates opportunity for, much service improvement, because we can just see things that weren't visible previously. But yeah, Fee, we just need to have a conversation about what the plan and process is around that. It's on my list. It's on a post-it, so now it has to happen. Fine. Let's go in and continue. I'll just share my screen again.
Francesca, has someone been through the booking process and timed it? Like, how long are we expected to take to do it? Is it quicker?
I haven't had somebody fresh and cold do it. But I obviously am experienced in the system, and I had to prep a load of patients this morning for antenatal inpatients, and they needed to have their booking totally completed, so their record is totally done. And just to enter the data, not to have the conversation, but just to enter the data, it took me 30 minutes.
Okay.
But also remember, you're no longer having to do Salus, that doesn't exist. You're no longer having to prep the booking packs, that doesn't exist. You no longer have to go through the long process on the paper referrals, that doesn't exist. So I think the system looks massive, and there does look like an awful lot of information. And what you see in digital implementations is that you have at least 2 weeks where everybody hates everything, and nobody knows what's going on, and everything is just a bit delayed and confusing, and it's called a J curve, because you have this point where things just hit the floor and it's a bit of a mess, and then within about 2 weeks people understand what's expected of them, the process is laid down, and then you see a massive soar in productivity off the other side. So in those first 2 weeks, one of the asks, Fee, that has been brought forward in quite a lot of the training sessions is about the amount of time that's going to be given to these appointments after go live. We're going to do routine antenatal this afternoon. I'll show you it. That one, super quick. I don't have any concerns about routine antenatal. That'll be fine. But people have mentioned about the volume of screens at booking. But I have offered that reassurance about there's loads of other things that you're actually not going to need to do. And also, when you get to the end of that phone call or that woman's left the room, you're done. You know, there isn't any additional pickups. But just to give you that feedback fee that I've had from a number of groups. And again, that's a conversation that we can pick up on the other side. But me now, knowing the system, having spent loads of time in the system, it's quick. And it's that thing that we've like let go of all of the other surrounding admin stuff that was distracting you from looking after your women, which is great.
I mean, I agree. I think we definitely need a little bit more time initially. How long does it take across, like, so if you look at Chelsea and West, how long does it take them to do a booking appointment now?
That's a good question. I'll ask them.
Extra time is an easy do, isn't it? Because I think your booking admin days are really not admin, are they? They're all sort of full of bookings, so we can just sort of spread that out. That's not a big deal. Fran, things like, so the things that take the most time to do referrals for are like safeguarding referrals, perinatal mental health referrals, Sycamore referrals. Are they all automatic, or do they?
So safeguarding referrals are an interesting one, and this is a conversation that I'm in that Kaylee's leading on. Essentially, when you do a SCMAF, it doesn't just go to Sycamore. As you know, it also goes to adult safeguarding, and it also goes to health visiting. So we're in this conversation about, do we need a SCMAF, or actually can we just have a process of using K2 reporting to pull off lists of women where there are safeguarding concerns for them to be referred on, and then other teams to pick up and look at them. So a decision hasn't been made at the moment. So because there hasn't been a decision, I'm going to say leave the SCMAFs until we can tell you differently, but I would like to get rid of them. That's the intent.
So I think the SCMAFs are okay. It's the safeguarding referral that needs to be done. So would you agree? Do you think doing a SCMAF is fine? Doing a safeguarding referral is a little bit more.
So the ones that go to social services, because they're going outside of Derriford, they need to remain. Because it's an external provider, we can't necessarily meet their requirements. Again, ongoing discussion about what information it is they actually need, because we might be able to pull it out of standard reporting. Once you've got these detailed mental health assessments, these detailed information about social profile, do you actually need the stuff that they are asking for, or is it because our records up until this point have been so bitty that actually you're not giving them what they need? So that one is for negotiation and discussion. Again, I'd like to make it go away, but I need to get buy-in from other stakeholders to make that okay. Perinatal mental health referral, the same. I'm going to put that in a post-it. I need to follow up with Kaylee about making those go. Sycamore referrals, though, they'll be easy, because what you'll do is you'll put through a referral to Sycamore team. So what Sycamore have asked is, when you allocate them to a team, you still allocate them to whichever routine midwifery team they would go to. So you allocate them to Southams, you allocate them to Green Arc or whatever, but you put through a referral to Sycamore. So they're behind the Sycamore door, so Sycamore can go and have a look at them. And if Sycamore are going to take them, they'll reassign their team. But if you just assign them to Sycamore in the first instance, they haven't been through that triage to be sure that Sycamore are happy to pick them up.
And then my last question is health visitor forms.
Oh, health visitor forms not existing, don't need to exist. Because we can pull off the routine reporting and send it to them. The problem was actually that, again, we didn't really have anything high quality that we could share with them. And if you look at, for example, the health visitor referral at postnatal, it's about 5 pages long. Lots of that structured data though, so it's pulled from other places along the way. So yeah, health visiting referrals, we still need to send them something, but it doesn't need to be a separate form.
And did we have the conversation, because obviously the health visitor referral forms are across the LMNS? So it's like a
Wilton-
standardised.
Charlotte Wilton's had that conversation. And my understanding is we don't need to use the routine form because we're providing so much more information.
Amazing.
Yeah.
So that's the same for the booking. We don't send them. And for GPs, do they get a copy? Because obviously at the minute we email a copy of the booking to the GP and the health assistants. They get a copy as well, the GPs.
So you still need to email it to them, but I'll show you how to generate it in a second.
Okay.
The other one that I'm working on, by the way, I've got a meeting this week about it, is about the epilepsy referral, because that's also a bit of a monster, isn't it? So I've got a meeting with Debbie Coker about, again, putting the patient behind the epilepsy door so that she can go in and assess them and it doesn't require any further information. But these are things that are going to come out in those materials that you have for Go Live. You'll literally be able to go through. They'll be in 2 formats. I'm making them available to print on paper if that's a thing that you particularly require. But there'll also be a Padlet, which is like an online system, which is alphabetical, and you'll be able to go through and choose your particular letter, and that will bring you up the information that you need about that thing. Happy days. But I've not made those yet, because every time I go into these training sessions, you end up in these brilliant conversations that I really enjoy, of like, what about this, what about that, how are we going to do this, how are we going to do that? So thank you. Any more on that before we go back into the system? Okay, so we've looked at type of care, care pathway. So the care pathways, they're not all in there yet, it's not all finished. Let me share my screen. Go through that again because I didn't show you how to get there. So we're going to go here, we're going to go care pathway. But again, you can change that at any point by going profile and in plan of care. You can change their care pathway. So, you know, if, for example, at 28 weeks, she suddenly had a GTT which shows she's diabetic, you can put her on the correct care pathway that way. So we're going to go here and we're going to go select care pathway. So Primip or Multip as the easy ones, but also our specialty pathways. Diabetes still needs to go in. Multiple pregnancy still needs to go in. I feel like there's a couple of others. But if, for example, for this lady, we are choosing Primip pathway and she, I don't know, has a BMI 35 or more, that generates the appointments that we would be expecting her to have, and we're going to document against those later. So what that does is when you go into consultations and admissions here, and you go to antenatal consultations, sorry, here, antenatal consultations, and then you go new consultations, which is how we're going to do routine community a bit later on. So don't worry if you missed that zip through the screen, because we're going to do it later. It now gives the list of all the appointments we'd be expecting her to have, and then you can record against those on the right hand side. But back to booking. So we're going to go back into our booking overview. And then overall risk assessment. So this is my little pink flower. So because of information, well, so it's not had one of these before, and we know that because it's got a grey flower over here. So based on the information that we have already entered, structured data, it's pulled some stuff through. So it knows that she's been allocated for CLC, knows she's a Primip, knows she's got a BMI of 35 and more. So are we saying this is a high risk pregnancy? Yes, we are. Are all relevant risk assessments undertaken and updated at this appointment contact? Yes, they are. Is she on the correct care pathway? Has she got a personalised care and support plan? Is her place of birth appropriate, and is her type of place appropriate? So again, those two are documented down here in case you wanted to check to make sure that you've entered the right thing. Any comments? And finish. So we've made her high risk, so now she's got a pink flower. So you can always identify that for her.
Fran?
Yeah.
Sorry, I'm unsure about the wording on that.
Which one?
If you go back onto the overall risk assessment, I just think if you've got somebody who previous PPH, BMI of 40,
Yeah,
type place of birth, she wants a home birth.
yeah,
Actually, if we're putting, sorry, my eyesight's shocking, I'm trying to read it.
Yeah.
Chosen type of place still appropriate.
yeah,
If we're writing no,
yeah.
that might irritate people.
But the patient's not going to see this. This is clinical.
Oh, okay.
side.
That's not
This is
going to
just
go
for
on.
us.
Okay. All
No,
right.
they won't see that. So, I mean, as far as we're concerned, if she's had a massive PPH and she wants to birth at home, it isn't appropriate. She can do it, like more than happy for her to do it, like brilliant. But that's not our advice, is it? It would be against advice.
Yeah, of
wouldn't it?
course.
Yeah.
Yeah. So she
Um,
doesn't see this. This isn't
no.
on her. Okay.
No, no, this is literally just for us.
Does the risk assessment or management plan that we did earlier, so when you did the smoker thing,
Yeah.
does that not pull over to this? Because obviously
No.
you've got that data there, but we did then that management plan separately,
Yeah. It
but that doesn't pull
through.
over.
It doesn't pull through because this is one of the places where K2 are quite thoughtful. I mean, they've given me all sorts of headaches in all sorts of places, but I have actually become, I'm quite, you know, I've got a lurking affection for them, because basically what they say is the system is clever, but the system is not a clinician. And there's all sorts of points along the pathway where they basically say it's not appropriate for technology to be making decisions. And this is one of them. So in here, it's clinician only. There's no structured data. There's no clinical decision support because it needs somebody without being influenced by what the system thinks to make a decision. Like if it had pulled, the system had pulled the data through, it's going to have an impact on the decision that you make and what you do. And that's why it's not in here. That's why this is clean. Because it's entirely for you to make a decision about what's appropriate for that woman. Does that make sense?
Yeah, no, that's fine.
Because one of the risks, one of the hazards that we did talk about for quite a long time in that structured risk workshop is about, so these things where, for example, it says, you know, you've entered diabetes, do you want to complete a diabetes referral? Or you've entered that she is a smoker and she's got a BMI over 35, so consider Clexane or whatever. That's called clinical decision support. And one of the real things that in the digital world we talk about a lot is about the impact that clinical decision support has upon practice. You have to be really careful that we're not going to de-skill clinicians, that we're going to support clinicians rather than really just help them to make good decisions. So there's lots of places where it would be lovely if the system did it, but that's why it's not, because we need to always safeguard and protect the ability of midwives to make decisions about the women that are under their care. Yeah. So that's why it's not.
I get that. I just think obviously because some things have pulled through, like her BMI's pulled through, but they're not that she's a smoker. Yeah. So then is it surely better not to have any information there to like, because you're then forgetting your potentially.
Get, if you remember, if we just do that again.
Yeah, show me again, maybe it's just me.
So you're going to get that at the front screen. So if we go overall risk assessment, you're going to get all that. You're going to get the list at the front screen. It's going to go, these are all the risks that the system has identified for her. You can see that she's diabetic. You can see there's maternal age. She's got a history. She's a primate, preterm birth.
We can't see your screen.
Oh, sorry.
That's all right.
Sorry. I want that on a t-shirt by the end of this program. So I'll close that again. And then go in here and you're going to do your risk assessment. The very first screen gives you all your active risk.
So it comes up there instead of at the bottom when you go through it.
Yeah. And then so we're going to go, so it brings this up, shows you all the risk on the front page, and then it goes assess now. That's the previous risk assessment we were just doing. And then after that, you've got the opportunity to fill in the screen. So it's given you the information and you now can make the decision. So is this pregnancy high risk? Yes. Have I done the relevant risk assessments? Yes. Am I happy with the pathway? Is it a personalised plan? Are they appropriate? and then next, and then finish, and then save. So now the next time that you do this assessment, because we're going to do it at every interaction, aren't we? We're going to press the button, please press the button, and it will show me, again, it will show me the risk. I also have the opportunity down here to add additional risks. If the system hasn't brought them over, I can add them here to make sure that they are appropriately visible. I'm going to go assess now. So we're going to see the previous risk assessments. I can see, okay, fine. So we haven't made any changes. It's all been as it was. And then we're going to do it again.
So actually that is more about, is she high risk, is she low risk, her overall kind of risk status, rather than the individual management plans. Fine,
Yeah.
I'm with you now. Yeah, that's fine.
And because what will happen when you hit the intrapartum setting, we're going to start talking about safer reviews. So safer reviews are interesting. So part of the work that I've needed to do on this system is one about generating a system that works for Derriford, but it's also about generating a system that works for Saving Babies' Lives version 3. And so version 3 has got some changes in the way that we do intrapartum assessment, for example. So Fresh Eyes is going to go away. Because Fresh Eyes, just that single look at the CTG hourly is considered not appropriate for full assessment. It wants a holistic assessment of all the aspects. So safer reviews are part of Guardian, and you look at the situation, you look at the assessment, evaluation, so things like recent VEs, colour of the LICOR, and then risks. And so in that assessment, all of these things that you're entering antenatally come up in that risk section. So then when you're hitting that intrapartum episode, absolutely all of that risk is readily visible, and a prompt when you're doing your labour evaluation of what she does or doesn't need, or what you should and shouldn't be doing. So that's a really important part of this bit of data collection. It's that so when we hit labour, we know what we've got and we know what we're doing.
Yeah. Fran?
Yeah.
Any chance guidelines are attached to K2?
Depends on which guideline, my friend. Which one would you like?
Any that's relevant. So I don't know. You've clocked that somebody's a smoker. They're 35.
Yeah.
And they've got a previous VTE. We know that they need, you know, antenatal clexane. But can I, if I'm in any doubt, can I pull up a guideline? Or do I have to just nip over to Toolbox?
You have to nip over to CAIR, and that's because in order to make them integral, every time a guideline changed, I'd have to run a system update, and that would cost a load of money. So I can't do it directly. I can sort of do the broad things, like I know in that situation she's probably going to need a referral, and that's fairly easy to add in those referral buttons. But text of guidelines would be an absolute logistical nightmare to manage. But there is some stuff. So you'll see, I showed you some earlier, some of the mandatory referrals, so places where we know they're going to need care, the system will automatically prompt you. Things like when you do the Muse, it will show you the guidelines for escalation. And also some of the stuff, Guardian's my favourite, love Guardian. Guardian has something called the plan function. And so basically when you indicate that a woman needs a specific care bundle, they're called. So, you know, now she's got an epidural, or now she's SHROM or whatever, it auto generates suggestions of things that you might want to do, and does that by clock, and then starts sending you notifications going, you probably need to do a safer review in 10 minutes, or you need to populate the fluid balance because you last did that 55 minutes ago. So yes, you're going to see a lot of that. And the thing that I love most about Guardian, my favourite, sorry to talk about Guardian in an Athena session, but just saying, is the Safer board. And the Safer board for me is the reason that I run this project. So the Safer board is going to replace the Labour Ward handover board. It's a big monster of a thing. The screen's about 2 meters by a meter, costs loads of money. the most expensive single element of this project probably. And the Safer board will take data from the portals. So you enter a VE on the portal, it's immediately visible on the label board handover screen. You do a set of OBS and suddenly she's scoring 2 reds, it's immediately visible on the label board handover screen. And also the plan and the interventions, and also the label board coordinator, the little screen at the moment that you can use to click on the CTG. The label board coordinator will be able to click on that and look at your notes. So if they look up at the screen and they say, oh, that looks like a bit of a Braddy, and then they click on your notes and you've just documented that was loss of contact, like the visibility of what's happening in the room was massive. But anyway, that's another day to be excited about. I'll stop talking about Guardian in the Athena thing. But let's get back to sharing. Okay, get back in. Ooh. I haven't yet been into confidential mode. So I know that if I try and complete the booking here, it's going to prompt me for the domestic violence question. If I try and complete the booking, yes, now I need to go into confidential mode. So it'll always make sure that you've been in. And we're going to go to confidential mode and you enter your password. So you know you're in confidential mode because it now looks purple up here. And on your social profile on this side, you've got some additional questions. So ask the question. Oh, so in order to get to here, you're going to have to go booking overview, take me back there. And then in my social profile, I've now got these, so I can enter this data. The question's a bit different from the one that we've asked previously, so do take a moment to read that. We're going to say she's not afraid at home and she's not been emotionally or physically hurt by her partner or someone important to her. And we're going to say domestic abuse is not a risk for this pregnancy. In here, if I needed to, I could also enter information about social services. And again, I'm just going to underline the point on this. So sometimes you'll click on a section and it won't give you that little red pencil to answer data. And you'll be like, Francesca, I can't get in. Why can't I do it? In that situation, you need to go to consultations and admissions. Make sure you're working in booking overview. That's where you can actually edit information. So you go in here, social services. If she requires a referral, yes, no. If there's any current social services concern or involvement, whether there's any historic, any in the household, external agencies. Finish. Safeguarding. If you have any safeguarding concerns and any referrals that you're going to complete, say no. And finish. And there is a did it again, profile, booking overview, child exploitation. There's an assessment in there as well. We're going to say that's not a concern. So now when I go down, it should just let me finish without that question and finish. Okay. Okay, so if you then want to send a copy of the booking notes, you're going to click export down here. Whether or not you want to enter the confidential information, and that is going to generate you a PDF. And it just takes a minute to get its act together. It's going to appear somewhere.
Francesca, can you get into the confidential mode if you're working offline?
Oh, that's a good question. Let's find out.
Because you have to re-enter your password, don't you?
So that's an excellent question. So if I go into offline mode and I search my assigned women, let's just take one of them over. So let's take Ella Adams. So she is now over there. And we're going to start offline. So now if we go into Ella Adams, confidential mode. Yep, still works. Okay.
Excellent.
So then you've then got your piece of information, which you know, sort of kind of looks like Salus, but loads more information. So this is what you're going to be sharing with GP at that stage. So as you can see, this is why I'm making the argument that actually potentially we can get rid of some of our existing referral processes, because the information kicked out of the system is now so detailed that the referral processes should become somewhat obsolete, I hope. Let's get rid of that one. Any questions about that bit? Anything that I've missed, or anything that you're like, how does this work, or any of that stuff? No. Okay, so we will briefly do the postnatal triage, and then we'll break for lunch at 12. So postnatal triage, how's postnatal triage going to work? Oh, so I need to come out of the offline briefcase, end offline. Okay, and we're going to remove her from the briefcase and then home. Okay, so postnatal triage, you're going to use my desk over here. And then what you need to use depends on whether you are doing weekday triage for your team, or whether you're doing weekend triage for the whole service. So if you're doing weekday triage for your team, what you would do is you would go here and you would choose team discharged women last 24 hours. So just go careful that you're not choosing team delivered women last 24 hours, because that just gives you the births. You need your discharged women. So discharge last 24 hours, type of stay, postnatal, or type of stay, antenatal, according to what you're choosing. So the team that I'm allocated to doesn't have any team discharged women. So I'll use all discharged women as an example. All discharged women is what you're going to use at the weekend. So you pick this one. So these are women that have been discharged. They're antenatal, postnatal. We'll use the antenatal as an example. So, oh, actually though, I do need a woman that's delivered. Okay, how am I going to do that? I know what I'm going to do. So if I go and discharge a woman, have I got anyone on Argyle that's had a baby? Kate Williamson has had a baby. And let's see who she is. Okay, so she's got all her stuff. So we're going to discharge her from the ward. It wants a risk assessment before we do that. Maybe it was not there yet. Well, home, none. Okay. Okay, so she's been discharged. So when I go back and go to my desk, now in discharged women last 24 hours, she's now there. So that's the point that I made earlier about please, 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 can we make sure anyone that's on the inpatient setting has been properly discharged so they can turn up for triage. So if you're triaging at the weekend, all discharged women last 24 hours, this is our postie. What you're going to do is you're going to go in and if you go to postnatal up here, you will cover this in the postnatal outpatient training as well, but we'll cover it here too. You can go over here and you can look at her delivery summary. So you can see all of the information about her delivery. And if someone has completed it, you can see her discharge summary. It's not been done yet. If it had been done, you'd also be able to see her baby assessment here. And then what you're going to do is you're going to go into your mother assessments. So these mother assessments, basically the purple sticker, baby check is the lilac sticker. So you're going to pull her up, you're going to review her records from delivery, and then you're going to go and do a mum assessment. And you're going to go add new assessment. So lots of things in here aren't mandatory. So for example, this can tell you automatically that she is 3 days since birth. OBS, if you were to see her in the community setting and you wanted to take them, you'd put them here. So a comment that you might also hear from me about cookie cutter templates. So a cookie cutter template is where, because we use structured data, I'm sorry for being techie, if you use a cookie cutter, it means that the system brings the data into all the right places. So we'll use mother assessment that looks like this for postnatal triage. We'll also use it for day 3s. We'll also use it for day 5s. We'll also use it for discharge summaries. So it will always be that same template. Same when we do antenatal consultations this afternoon, regardless of whether it's routine midwifery antenatal or whether it's consultant antenatal or whatever it is, the template is the same. You just need to choose the right information. So some of the things on this one you're not going to fill in because it's telephone triage. So set of OBS in case you were with her to do them. We're going to say she's got good perfusion, she's got normal lochia, it's not offensive, she's alert. Fundal height for phone triage you're obviously not going to do, but what you are going to do is you're going to nominate that it's a telephone contact. So if anyone's going back through and looking at this assessment and going, actually, why didn't they palpate the uterus? It's because you've indicated this is a phone contact. So that one's quite important to make sure you fill in, please. Whether or not there's perineal trauma, whether she's got sutures. These things also should be structured data. So they should pull through from the information entered after delivery. So you'll know that she's got sutures, you'll know that they're dissolvable. But then pieces over here about whether there's any concerns with the perineum. These, of course, are for face-to-face appointments. Whether if she'd had a section about the abdominal wound, and again, this should pull through from delivery, so you'll be able to see what the skin closure is. Swabs, if you see them in person. These are anaesthetics questions. Some detail on the anaesthetics. Questions about breast and nipples, questions about legs, questions about pain. Pressure ulcer assessment, if they've had a previous assessment. Questions about the bladder, and I'm sorry for the next screen. Didn't put it in there, wasn't my choice. It's mandatory, I can't get rid of it. I have a stool chart in case you do need to go into any deep detail about what's happening in that situation. Questions about postpartum psychosis, fatigue, emotions, postnatal exercises. And that's your mum assessment. Also here, so as I said, because these replace the purple and lilac stickers in all the places, if she had had a check on Argyll, you would be able to see that alongside this one. So before you do your postnatal triage, you'll have a bit of insight into what's happened previously. You can go look at that. And then the other one that you're going to do is you're going to do your baby check. Which is not going to let me do. I don't think this baby has been properly delivered. So let me go and find one where I do know the baby's been delivered. She's definitely had a baby.
So how are we going to access this information up on the wards then? Are we going to have more computers?
Well, 2 ways. So Argyll and TCW are going to have tablets alongside the PCs. I might also hustle a few laptops on trolleys in if I can talk the ward managers into it. FYI on Argyll, so the portals that we're currently just using for CTG, you will be able to use those for documentation as well. And I'm having keyboards fitted so that it's easier for you to be able to enter that information. But you can use tablet or PC or the portal, depending on what suits you. So this woman, she's had all of her documentation done. So let's do that process again for her. So you'd click through to the record. When you click on postnatal, it actually gives you the options here. So these are mother assessments that she's had previously. We're also going to do a baby assessment for postnatal triage. Now, again, telephone contacts, birth weight. You'll see this in postnatal outpatient, but this is one of my favourite things about the system. So baby birth weight 2999, it does the calculation for you about the weight as to what it's lost. So if you see it now and it's 2756, you know that it's lost 8.10%. You don't have to do the maths. How exciting. Anyway, obviously you're not going to do that for telephone triage. Skin and colour, jaundice, mouth and gums, bowel status, comments on bowel status, PU, comments on PU, cord, sleeping. The thing that it doesn't do in the baby assessment is feeding. So what I would need you to do for that is to go into postnatal. Or is it in baby? Might be in baby. Yeah, you should press the green baby button and then go into feeding. And I'd ask you to run the wizard in here to assess the feeding conversations that you have with mum for triage. So that is her triaged now, and you are happy with her, but you need to book her ongoing appointments. So what you'll be able to do, I'll stop sharing for a second. So routine day 3, day 5 appointments are staying on Outlook. So you'll be able to book those in. Where you need a postnatal discharge for your woman, you'll be able to put through a referral to the community midwifery admin door to book her postnatal discharge. So you'll have that better oversight of the referral when it was made, and you can go back in and look to see when it's been actioned. And so the admin team will go through, complete the appointment on IPM. You'll be able to see it and when it's made for, and she'll be able to see it on the portal so that she's got insight on when her appointments are. The Outlook appointments will not appear on My Pregnancy Notes, so you'll need to just underline that to make that clear to her that she can't use that record and that she knows when they are. So that's the plan for postnatal triage. Feet on a cliff, how do you feel about that?
I quite like it.
From you, that is high praise.
So do you know what my little brain is sort of thinking from a risk point of view, this is huge. From a, trying to find information for day texts, this is going to make life very easy.
Yeah. Thinking about risk, there is one thing that I need to mention. And again, this is why I love these training sessions, because the stuff that comes out of them, someone raised this the other day and I was like, I'd not even thought of that. So put process in place around it. So the situation that was raised was, what about if you have a woman who is discharged home like 6 o'clock in the morning, and then she's for postnatal triage that morning, but someone takes pity on her and goes, you know what, she probably only got home an hour ago. I'm not going to call her now. I'll call her a bit later, or she can have a call tomorrow or whatever. And then nothing is done with that because you're like, oh, you'll ring her later. And then the next day, when they pull the details for triage, it's going to be women last 24 hours. And actually, she'll have been missed, won't she? Because she's not going to be last 24 hours anymore. And also women who don't pick up the phone. How do we deal with those people if we've got to the end of the day? So we're going to generate a door, which is going to be called something like triage pickups or something like that. So if it's that situation where you've not been able to get hold of them, or it's, you know, a bit too early for a call and you need them called tomorrow, we're going to send them to triage pickups. So when you're doing that postnatal triage, you